Good morning. My name is Alexi Potter. I'm a professor of psychiatry at the University of Vermont. And in my talk today, we'll talk about the non-imaging assessments that are part of the HBCD study. I want to start with a thanks to Wes Thompson for inviting me to be a part of this talk today, and also to the HBM committee for allowing us to describe what I believe is going to be a really valuable resource to our imaging committee, and that is the data from the HBCD study. So you've heard already about the structure of the study. What I want to talk to you today is about how the assessment work groups have gone about determining what are the measures we're using in each visit. I'll draw your attention to the upcoming special issue of Developmental Cognitive Neuroscience, in which different assessment work groups have all written chapters presenting the specific methodology and the details of the assessments that are included in the first data release. HBCD assessment batteries are all chosen through the work of assessment work groups. The work groups include domain experts, including research staff, who review the available kind of methodology and recommend assessment batteries to the consortium. The work groups also train research staff on data collection and QC the data as we go on. Underlying all of the assessments that were selected were a core set of kind of guiding principles that we prioritize measures that are empirically linked to developmental outcomes and to prenatal exposures when possible. Choose assessments that are psychometrically sound, developmentally sensitive, and that is, as you know, the visit windows span several months, so picking constructs that we can measure well across that entire window. Always trying to prioritize measures that are as short as possible to reduce burden, and all measures have to be available or appropriate in both, to be given in both Spanish and English. I'm going to focus on the first 3 visits today because that's what will be included in the first data release. So visit 1 is a prenatal visit when people are in their 2nd or 3rd trimester of pregnancy. And this visit really obviously is focusing on the prenatal environment. So there's questionnaires for the birth parent on demographics, on maternal mental health, substance use, and the substance use is done both through a brief survey of use and then a detailed timeline follow back for any substance that has been endorsed. A focus on protective factors, including positive experiences and social supports, trying to get a very rich understanding of the environmental context, and also family history of psychiatric and substance use disorders. There are also biospecimens collected from the birthing parent, and those are designed to measure exposures during pregnancy and early life, as well as genetics, epigenetics, and stress signals. So in that first visit, the pregnant person contributes blood, nails, urine, and saliva. There are also a series of pregnancy check-ins that then happen at 34, 38, and 42 weeks, at which we update the due date and the health of both the pregnant person and the child. When the child is born, their first visit is within that first month of life, and that is a visit that includes MRI. It also includes the first questionnaires that relate to the health of the baby, so birth outcomes and the child's health. We get an immediate breastfeeding history, how that baby is, what the nutritional status is at that point, as well as measures of maternal mental health, social support, and the maternal substance use since the period that we last measured that. Biospecimens now include both maternal and child samples. So nails and saliva are collected from the mother to get environmental exposure and genetics. And for the child, we're collecting urine, stool, and saliva to, again, measure exposures, to get a measure of the microbiome and some genetic information as well. And these biospecimens are also the same at visit 3, which I will cover in a moment. At visit 2, with that baby between 0 and 1 month old, we're getting physical measures. So we're measuring the length, weight, and head circumference of the babies. And this is also the visit where we introduce wearable sensors. These are, again, worn at visit 2, visit 3, and then throughout the rest of the study as the child ages. The infant sensors there are 2 different types of sensors we use. The first are infant movement sensors. And these are shown on the left of your screen here. So they're worn on each leg right above the ankle. They're worn for 72 hours. Parents complete a daily questionnaire about the child's activity during that time. And then the sensors are returned usually through prepaid mailers back to the site. As you'll see on the left, the sensors include the small sensor that's put into a leg warmer, a pocket in a little leg warmer, which are put on the baby's legs. That middle picture shows you a child wearing the leg sensors. And from that data, we can get sleep-wake cycles, amounts of physical activity, as well as movement patterns there. On the right-hand side, you'll see a baby wearing the heart sensor, the heart rate sensor, the Gabby device that we use. These are also worn for 72 hours, and again, accompanied with that daily questionnaire that just sees if that 72 hours was typical. And these measure continuous heart rate, and also then we can get heart rate variability from them. We next see the child when they are between 3 and 9 months of age, and now we begin to be able to get a richer assessment of the child. So first, just highlighting things that are the same between that visit 2 and visit 3. So the biospecimen is the same, the physical measurements of the child are the same, and also those wearable sensors are repeated for 72 hours at this age window as well. The questionnaires now start to really focus much more on the child behavior, or start to include that in addition to the things they have always focused on. So now we're getting initial measures of child irritability and crying patterns, sensory processing, the child caregiver relationship, as well as making sure we're continuing to measure maternal mental health, social supports, and maternal substance use the same way as before, detailed timeline follow back as for any substances that have been used since the last visit. We're now able to get our first direct measures of a parent-child interaction task. We're using the ERICA, the Early Regulation in Context Assessment. In this assessment, the caregiver and the child engage in a series of brief everyday activities. Some examples are like dressing, playing, washing, those types of things. These interactions are standardized, they are videotaped, and then they are coded. And there are different sets of activities for developmental levels. So this visit window encompasses from 3 to 9 months. And so there's one set of activities for kids before they are able to move around, before they're crawling or moving independently, and a different set for after. I'm very excited that within the context of these assessments and the videotaped coding we're doing, we're also measuring family cultures, this measure called Family Cultures Matters, which is a Q-sort activity that's designed to capture important differences in what caregivers value and desire for their child. The way this is done, there are 15 qualities that the caregiver organizes into 3 different bins: very important, important, and less important. And then in each of those bins, which can contain 5 qualities in each, they rank them in order from most to least important. And examples of the type of qualities are things like, how important is it for your child to be a leader, to have a calm temperament, to be loving, to work hard at school. And so I think this is really exciting because it lets us get an objective measurement of the person's values, and we can then see how that coding of the actual behavior fits into the values for that family. We also are beginning at this visit to get our first measures of cognition and language. We've elected to use the NIH Infant and Toddler, or the Baby Toolbox, for this early measure. The toolbox will then be used longitudinally at further visits, and then supplemented by other kind of gold standard measures like the Bailey Scales of Infant Development at later ages. But the Baby Toolbox includes modified versions of the Mullen Scales of Early Learning. And so we're using those tests of expressive language, receptive language, and visual reception. And then it also includes a series of tasks that use eye gaze technology administered via an iPad. Beginning at 6 months of age, infants can complete these eye gaze tasks, and they measure things like language with using looking while listening, measure executive function with a habituation of familiarization task, and also early numeracy with a numerical change detection task. So at this visit 3 to 9 months old, we're starting to be able to get a pretty rich characterization of babies' emerging skills, parent caregiver-child relationship, as well as continuing our measure that we get through questionnaires, biospecimens, sensors, and combining that with our brain imaging measures. Um, Thanks. I'm not there to be able to answer questions, and so I refer you to the HBCD study website, as well as my email if you have any further questions. Thank you.